Hi, I am Igor, and today we will go talk about Takayasu arteritis and microscopic polyangiitis. Takayasu arteritis is granulomatous inflammation of the aorta and its major branches, resulting in thickening and stenosis of the involved blood vessel and subsequent vascular symptoms. Epidemiology: peak incidence is between 15 to 45 years of age. The most commonly affected individuals of Asian heritage, more common in women compared to men, 9-to-1 ratio. Clinical feature is non-specific, such as fever, malaise, arthralgia, night sweat. Vascular symptoms is decreased bilateral brachial and radial pulses, so-called pulseless disease, syncope, angina pectoris, bilateral carotid bruits, impaired vision, movement-induced muscular pain in one or more limbs, Raynaud phenomenon, and hypertension. Skin manifestations include erythema nodosum and urticaria. You can take a pulse in Takayasu arteritis, pulseless disease. Diagnosis based on general principles is clinical manifestation, but also requires confirmation with imaging or biopsy. Non-specific laboratory findings may support the diagnosis. Is increased erythrocyte sedimentation rate, increased C-reactive peptide, leukocytosis, and anemia. Major studies include angiography, MRI, indication prefer initial study for all patients. Findings we see thickening and contrast enhancement of the vascular wall due to inflammation, luminal stenosis or occlusion. Echocardiography is considered for all patients to assess for aortic regurgitation and ventricular hypertrophy. Alternative is CT angiography, more readily available and has higher resolution than MRI, findings similar to MRI. Angiography, considered for patients with planned vascular intervention, for example, angioplasty or stenting. Detects vascular stenosis. Diagnostic confirmation frequently relies on imaging, as biopsy is not always possible because affected vessels are often inaccessible. Indication for biopsy is not routinely required. Considered for patients planned vascular intervention. Supportive findings: we see granulomatous thickening of the aortic arch, plasma cell and lymphocyte in the median adventitia, and vascular fibrosis. Treatment is based on high-dose glucocorticoid initial therapy plus glucocorticoid-sparing agent, for example, methotrexate, azathioprine, cyclophosphamide, TNF inhibitor, infliximab, and subsequent therapy based on response to initial therapy. Surgical therapy indication is selective procedure, progressive ischemia despite escalation of immunosuppressive agent, emergency procedure, critical stenosis of the aortic arch or its branches. Surgical intervention include vascular bypass, vascular grafts, percutaneous transluminal angioplasty, and stent placement. Microscopic polyangiitis is necrotizing vasculitis of small vessel, typically with pulmonary, renal, and skin involvement. Manifestations are similar to granulomatosis polyangiitis. The nasopharynx is usually not affected. Clinical features include constitutional symptoms, weight loss, fever, fatigue, malaise, renal palsy, immune glomerulonephritis with hypertension, lungs, pulmonary vasculitis, lead to diffuse alveolar hemorrhage and hemoptysis, skin palpable purpura and nodules, and necrosis. Gastrointestinal include abdominal pain, GI bleeding. Neurological is mononeuritis multiplex, distal symmetric polyneuropathy. Clinical features are very similar to those of granulomatosis with polyangiitis, but microscopic polyangiitis spares the vessel in the upper respiratory tract, no sinusitis or rhinitis. Diagnosis: primary clinical and confirmed by biopsy. Chest imaging is required for all patients with lower respiratory symptoms. Laboratory studies include inflammatory markers, increased erythrocyte sedimentation rate, C-reactive peptide, CBC, leukocytosis, thrombocytosis, and anemia, serology, neutrophilic cytoplasmic antibodies, is myeloperoxidase, NC, and proteinase 3 antibodies. Urinalysis is proteinuria, microscopic hematuria, and erythrocyte tests. CT test indication patient's lower respiratory symptoms, finding ground glass opacification and nodular lesion. Biopsy of involved organ is confirms the diagnosis. Absence of granulomas, fibrinoid necrosis with neutrophilic infiltration. Microscopic polyangiitis has myeloperoxidase antibodies. PNK. The absence of granulomas on histopathology plus PNK positive helps differentiate microscopic polyangiitis from granulomatosis polyangiitis, as they have very similar clinical features. Treatment general principles is goal of pharmacotherapy, glucocorticoid plus cyclophosphamide is induction of remission, and plasmapheresis is only considered for patients with severe end organ damage. Thank you. Subscribe to the channel.